All right, well, it's week 5 already. It's almost halfway through the course, and it goes really, really quick. Today, we're going to have a PowerPoint, and we're going to try to get in a Kahoots, maybe a short one, long one. I've got a couple different options that I'll let you choose. And we're going to be going over chapters 23, 24, which is the child with sensory or neurological conditions, and the child with musculoskeletal conditions. Remember this week, you have a discussion question. Those people who were late, didn't turn it in, I did last night send a message to remind you. Just get it into me before Sunday, and I will be okay with that. Make sure you do your 2 peer reviews also. You do have some NCLEX questions due, and you have a case study on the compound fracture. Remember, compound fracture is open, so it's open to air, so it can get an infection. And then when we're done, we're going to do quiz 3. Now, next week, you will have an exam. Try to get to class a little earlier, so as much as you can, so I can set you up and get your tests going, and then we could have class afterwards. Come in on your iPhone or your phones or another device. And then after you're done with your exam and you've uploaded, you can go and get onto your computer that you will use. Your attendance is that you're going to come back in the time I tell you. So if you have an exam starting at 6 o'clock, you should be back for class at 7:20. So if you're back at 7:20 and you're back on your computer, on your Zoom, then that is counted full credit because you did your exam, okay? Any questions, comments, concerns from anybody?
Ms. Bogart, for the case study, I didn't see it on my, like it's not open yet, did you say?
Okay, I will go back and I will check that to be sure.
It's not due until next week on our end on Canvas.
Yeah, it is for you to start. It is now open, ready for you. It should have opened. And you're telling me it's not open?
Yeah, it's not open for me.
Okay, I will make sure I get that done for you.
Thank you.
No, thank you. See, if I don't know these things, I can't help you. So I appreciate you helping me to help you. So thank you. So let's go ahead and start with our PowerPoint. Remember, from exam 1, I'm still doing reviews for people. Anybody who wants to go over it with me, please make an appointment and I will spend the time and let you know where your faults were. And if it's something that I can help you on the next exam, or if it's math, for instance, I can help you with all of these issues to try to help you do a lot better. Maybe it's you read the question wrong, okay? So I'm here to help you, but you have to ask. If you don't ask, I don't know, okay? So let's start here. Excuse me. So we're going to go over chapter 23 first, and it goes over, a lot of different things, and it's a lot of different, information that we see. But we're going to start out with infections of the ear. Now, there's 2 types of infections in the ear. You have one that's on the outer canal, and then you have one that goes in the middle ear. Now, they both hurt. They both require treatment. The one that's on the outer ear, they describe it as swimmer's ear. It could be something that was left in there causing an irritation, and it hurts. And even when you touch the ear, it's very, very painful. Now, we do make sure that there's nothing else that's going on. I've seen ears that have had roaches in them, crayons in them, and earring backs. So sometimes it's something that's in that canal that's causing that problem. So the treatment, we'd irrigate it, and then we give something like drops into the ear. It's not an oral antibiotic. Now, acute otitis media is in the middle ear, okay? Media, middle. And what happens is it gets full of mucus. Now, children have very short, wide open tubes in their ears. So they get mucus from an upper respiratory, and guess what? It goes right up into the ears and it starts to bulge. Usually it's an infection, and we always treat it with an antibiotic. The number one antibiotic that we use will be a amoxicillin. That's usually the first line. It's usually a staph infection, and we need to make sure that the child comes in, mom's saying something's wrong, they're not eating. Not all the time they're young enough, the younger kids, they can't tell you. But if they're like touching the ear, even infants, and they're rubbing their ear on the bed, or you see them grimacing, or you see those signs of pain, something's wrong, and you check those ears. Now, sometimes children have had an ear infection, or that child who is really apt to a lot of ear infections. You're going to hear, it's going to cause a hearing loss. Now, the one thing that you need to remember is hearing and speech go hand in hand. If you can't hear, your speech is going to be garbled. It's not going to be clear. The pronunciation is not going to be where it should. So what are we going to do if there is a speech problem? Number one, we're going to do a hearing evaluation and sending for a hearing test. Of course, first looking to make sure nothing's in there. Now, a kid would also have, like, they talk loud. Well, kids normally talk loud, so maybe that's not what you see. But what if the kid's sitting in the corner name and they're not answering because they're not looking at you? That's probably telling you they can't hear. And again, that articulation and that speech for sure. So when you look inside the ear, you see this redden and you'll see it bulging. Sometimes it ruptures and you'll see like this purulent drainage. It could be yellow, tannish, and maybe a serosanguinous. And this is the eardrum has now burst. So the treatment still is antibiotics, still do the same thing. Sometimes with those, we might put eardrops and oral in there. Now, if we have a child with chronic ear infections, and we are chronically putting them on antibiotics, we might have to do a surgical intervention. We put tubes in, and usually if we do tubes, in pediatrics, we'll do the tonsils, adenoids, and we'll do the tubes all at the same time. Now, as nurses, what is our role? What do we need to do? Well, we need to tell these, mom, dad, even the children, after 2 days, maybe 3, they're going to feel so much better. And many parents stop taking those antibiotics. But what happens is you don't take the antibiotics the whole course of it, and you didn't get rid of all that infection. And now you're going to have another infection that's going to reoccur. And multiple reoccurrence of ear infections can cause hearing damage. So we don't want to do that. Now, hearing impairment in children, many children don't hear well. We actually do a hearing test before they're discharged from the hospital as a newborn. Now, talking with a kid that we know has an hearing impairment, there's many different ways they communicate. They can lip read, they can do sign language, they can show you picture boards. But remember, any patient, especially children, the way that their body language is, are they in pain? Are they happy? Are they anxious? It's very easy to tell with children. Now, a clue. When talking to a child who is hearing impaired, you need to be at eye level and face to face, and they need to be looking at you. And you're just going to talk, not loud, not exaggerated, but in very short sentences, and making sure they understand in between. Now, that kid is, most of the time, if they've been hearing impaired, you're going to be able to understand this very short, sentences that you ask. Now, let's talk about some eyes, things that goes on with the eyes. Well, sometimes we have something called strabismus. Now, usually by about, I would say 4 months, you have children who, when they're born, have one eye looking and the other eye looking, and they're not working together. Like you or me will take a point, put our finger and put our eyes there, and they're both going to go to that point. So we got great depth perception. With strabismus, you do not see that. You do not see that at all. Kids are born binocular vision, which means that's the way they are. And they, by about 4 months, they'll clear up. Now, another thing, the kid gets older and we haven't picked it up, or we haven't corrected it yet. You're going to see a kid cover an eye to be able to see, or they're going to, move their head to try to figure it out. But if you can imagine seeing two different objects with each eye, that's going to get confusing and you're going to get dizzy and get headaches with it. Now, strabismus, how do we take care of this thing? Well, usually it's one eye that seems to be more than the other. And the eye that seems to be the issue is we're going to leave it unpatched. We want to make the muscle work because it's usually muscle. So we cover the good eye and let that other eye work. And it will strengthen the muscle. Then also is we're going to, sometimes they're going to need glasses, and that glasses also can help. There's something else, that we call is amblyopia, which actually looks like this picture here. It's that lazy eye, same sort of thing. Cover the good eye and let that bad eye work and let it, take care of itself. And then there's another thing in eyes called nystagmus, and the eyes twitch forth. And many times in that one, again, we patch alternate eyes, try to make those muscles work, or we have to do some corrective lenses on them. Now, sometimes we get some eye strain, and eye strain could be caused by many things. I mean, you have a child who hasn't gotten, glasses yet. Is they're squinting, trying to see, which makes their eyes hurt, they burn, they're inflamed. And because they can't see the board, like in school, they get really short attention spans. They can't see, so they really don't know what's going on. Our interventions is we got to tell them, if they have glasses, they need to, use them. Or if they don't, we really need to make sure they get to that eye doctor to get some glasses. I mean, eye strain, they're going to have those headaches because, again, they can't see, they're squinting, and they're not going to be able to do schoolwork. And as I said, they can't see the board. Another thing with the eye is something called a retinoblastoma. Now, retinoblastoma is this thing that happens with children, and it happens because there's a tumor in the retina. Now, the thing that you see with these children is this white spot. Have you ever opened your back door and there's a light on and there's a cat, a deer, a bear, a dog, and you see these shiny white eyes? This is what you're going to see with these children. It's called a cat eye reflex or leukocoria, but it's that white shiny thing. What happens is you're going to go through all different stages with this eye. You're not going to be able to see. You're going to have, of course, it's not going to focus. That's strabismus. It's going to get swollen, with edema. And of course, it's going to hurt after a while. Now, how do we treat a retinoblastoma? Well, it is extremely cancerous. And we're going to try to do a little bit of radiation, which is that beam. And they're going to put this little purple spot on their eye with a dye, with a marker. We don't erase that. We don't wash it off. And they just put beams of radiation there. And if that doesn't work, or sometimes they do it in combination with chemotherapy, usually they have to remove the whole eye because, if you don't get it all, it's going to end up metastasizing. So they end up with a false eye. Now, one of the things that is a concern is all of a sudden you have this kid who's fine, or maybe they had fallen down, they're just under observation, and all of a sudden one of their eyes, those pupils become big and they don't move with light. This is an emergency. What it's telling you is there's pressure in the brain in that area, and it's that pupil is dilated. It's telling you it needs evacuated right now. So a fixed dilated pupil, emergency. Now, we talked about a fall, and we talked about this fixed dilated. All right, levels of consciousness. You know, we do examine them for many different reasons. We do that in case they're on medications that maybe we gave too much or it was too much for that child. They've fallen, we need to evaluate them. But there's one thing that you'd see that level of consciousness that you wouldn't think of, and that's low blood pressure. But just think about it. You get a low blood pressure, what happens? You get less blood flow to the brain, so you cause cerebral hypoxia. Also, if you see your CO2 go high, again, that's another thing that stops your level of consciousness. Fevers, you can get really, confused when those fevers are being high, because again, you're using oxygen. We know sedatives, anti-epileptics, absolutely decrease the level or alter the level of consciousness. Anti-epileptics numb the brain, so the brain's not going to have seizures. If it numbs the brain, it's really sedating you. And then if you have a seizure, grand mal, and it's finished, there's going to be this postictal state where you're awake, but you're not there, you're confused, you're disoriented. You have an altered state of consciousness, absolutely normal for this. And then anyone who can have an increased intracranial pressure will have an altered state of consciousness. These are all of your nerves, that you can look at. Cranial nerves, there they are. So if you're seeing different things, we know what nerve to check. If we're concerned about the area of the hypoglossal nerve, we could say, stick your tongue out. And if you can't, we know what's going on, where this damage to the head could be. So cranial nerves can be used that way. Now, I love this acronym. Once one takes the anatomy final, a good vacation seems heavenly. And that will let you know all of the different cranial nerves. Now, have you ever heard of Rey Syndrome? Rey Syndrome is something that happened right before the advent of acetaminophen or ibuprofen. Years ago, all we had was aspirin for fevers or whatever. And kids ended up getting Rey syndrome because of aspirin. Aspirin, is only used in children for one diagnosis, and we'll understand that when we get to the cardiac unit, that area in the book. It's the only time we use aspirin. Aspirins are dangerous in children. And what it does is it causes an accumulation of ammonia in the blood, this metabolic thing that goes on because of the liver. And then this liver dysfunction, liver has a lot to do with bleeding. So you're going to be prone to bleeding. So you're going to see cerebral edema, increased intracranial pressure, altered level of consciousness, seizures, coma, vomiting, and then, of course, your altered behavior. This is all from Rey syndrome due to an aspirin. So with all those symptoms, what's the treatment? Well, we want to get that pressure down as soon as we can. We want to, of course, keep that airway, especially with possible seizures and all that. And we want to make sure that the cerebrum is oxygenated, and we're going to be monitored those fluid electrolyte balances. And of course, one thing we're going to do is be monitoring anything that has to do with that liver dysfunction. So we always discourage it. If a parent asks you or thinks they can take it, tell them no. Do not. Advise them to read it because it will say there not to give it. Because usually they have a fever at home, there's nothing else. I would tell that parent, give nothing if you have nothing else, because aspirin is that dangerous for them. Now let's go into meningitis. Now, your brain and your spinal cord has a meninges, which is this covering that protects it. And it can get an inflammation and infection due to a virus, or it could be due to a bacteria. Now, the symptoms that they come in with are really similar, very much the same. You're going to have a chills, headache. Man, if my meninges are all inflamed, I'd have a headache. Then you're going to have this inflammation in the brain. You're always going to have that vomiting. Headache, vomiting, they go hand in hand. That neck is going to be stiff. We call it meniscus, where the head, if you try to pick up the legs, the head comes up. Pick up the head, your legs will come up with it. It's all part of an assessment for assessing for meningitis. These children, even adults in meningitis, the symptoms basically are the same, except a couple over here. But these kids, the light bothers them, sound bothers them. They're just confused. They're going to be rapid breathing, a lot to do with pain, with agitation, and this upsophthalmus, which is that neck stiffness, which again, that meniscus, okay? Now, infants, they tell you a lot with just that little soft spot in their head. If we see it being swollen and it wasn't before, and this is at rest, not crying, this child has an infection in the brain, and it can give you that sign, yes, this child is a meningitis. And we know children, whenever they're sick, what's the first thing they do? They stop eating. They'll, even if you want to feed them their favorite foods, they ain't going to eat. No. Now, here's some different signs that we look at for that neck stiffness, to make sure that we are diagnosing meningitis. Brudzinski, this Brudzinski's sign, it's a neck stiffness, and then you pick up the knees and your head comes up with it, okay? And then turning sign is like when you try to straighten the leg again, your leg comes up. So the knee and the neck and the back are all interconnected. So how do we diagnose meningitis? Well, we have an assessment. Maybe we have lab works. Maybe it's showing a CBC with elevated white counts, or maybe not. But you have all the assessment that you can see, the neck stiffness, etc. We're going to do a lumbar puncture. The lumbar puncture is when you go into the spinal column and you get fluids. Sometimes you use cerebral spinal fluid. If you have a chance and go in and you are assisting the physician, if you see clear liquid coming out, it means usually it's a viral infection. Now, if you see white, milky-like substance, that one's going to be a bacterial infection. And that white, milky stuff, what you see is white blood cells. What are you going to see with this child with these white blood cells? Well, besides white blood cells, you're going to be looking at the rest of the thing that they do, the lab does. They're going to look at proteins. They're going to be elevated. And the sugar and the cerebral spinal fluid is going to be low because bacteria love sugar. So when you see elevated protein, decreased sugar, white blood cells, bacterial meningitis, you know for sure. So now that we've diagnosed it, what are we going to do? Remember, when you get a kid who comes in, clear fluid, milky fluid, until you get a complete diagnosis and this, the culture sensitivity reports back, All children are, you treat them like they are bacterial, okay? Which means they're going to be placed in a drop-in isolation for 24 hours. There's special rooms that air doesn't go back into the hospital. And as a nurse, you're going to be wearing your N95 mask, protecting yourself. Now remember, this is this inflammation of the brain. So we're going to be doing neuro checks on these children. We're probably going to give some sort of steroid. And because it's inflammation of the brain, we want that to come down. We want to have those fevers down. And of course, that child is going to be placed in a room that's quiet. Now, as nurses, we're going to be looking for signs of things with the brain, like weakness of the limbs. I mean, strokes and whatnot is part of this. If you look at these symptoms, speech difficulties, mental confusion, behavioral problems. And like with anything that's with brain or trauma with the brain, you always need to be very concerned about intake and output. Too much intake can cause extra swelling on the brain. We don't want that. And as again, I said, a quiet environment, close the curtains, TV very low, if on at all. It really, really does bother them and cause them severe headaches. Now, some children do get seizures. I mean, meningitis, inflammation in the brain, yes, absolutely, you can get a seizure. What's something that could trigger it? Well, they're saying that if there's like these lights that are like flashing, so dark to light type thing, like in a disco or like in a rave, those lights going like crazy, that can cause a seizure. Sometimes if they're startled, you walk in, let's say like you slam a door, loud noise, and it makes them jump, well, that can cause it. Look at this, that overhydration, increased cerebral fluid in there, increased pressure in the head, and of course, that photosensitivity. So treatment, what do we do if your child has been determined a seizure? Well, what's the type of seizure? We know one type of seizures is a febrile seizure, where an increase of a temperature from 0 to a fever in 20 minutes can cause a seizure. And that's a febrile seizure. And they're basically benign unless it's frequent and becomes more and more frequent. Usually you'll have maybe 1 or 2 of those and the kid grows out of it. But what if you're having, 2 a day or 5 a week? Now that needs to be looked at. What's going on? What's happening? So you need to determine what type, what's going on. So we're going to do some diagnostic tests. We're going to be doing a CAT scan. We want to look at the brain. We also want to look at the spinal column and then maybe do an MRI. This little picture of this kid getting the EEG, I've seen it done for even these newborn infants that they were concerned about possible seizures on them. And you can watch them, absolutely, all of the little tickings like you see down there. And I've seen actually, if you have a loud noise or if the door slams, you will see spikes that the brain does react to these sort of things. That's why you need that quiet environment for those kids, like with meningitis, because it affects the brain, you can see. Now, what drug do we choose? They're all different. Some young babies are just on phenobarbital. Older children, maybe they're going to be on phenytoin or Dilantin. All different things. It depends. And then they keep adding things on until they get those seizures under control. One of the things that's interesting is these diet changes. Yesterday, I literally watched a documentary on a child who was 4 years old and had seizures and was autistic and had multiple seizures per day. And they put this kid on a ketogenic diet. And within 2 weeks, this kid's seizures decreased. Within 4 weeks, they were decreasing their medicines. And this kid now was actually more verbal than they were before. So diet is huge. There's all different treatments that are out there. So diet would be something that maybe parents might consider. So knowing the type of seizures, is important, treating them. And, remember the child can tell you a lot about what's going on. They can tell you if they know it's coming. So remember, part of the care, include your child. It's going to be important information. Young ones can tell you a lot. Okay, you walk into a room and a kid's having a seizure. What are you going to do, right? That's nursing care. What are we going to do? Well, hopefully, the child already has the side rails up. Any child with a history of seizures is going to be, prone to get them. So side rails up, keep them protected. And of course, you're going to pad those side rails to make sure they don't hurt themselves on it. If it's a kid who's up and around and moving, there are some sharp edges on beds and cribs and dressers, etc. We're going to need to pad them. This kid goes home, you're going to need to pad the furniture so they don't hurt themselves. Today we do have, for the older kids, they have phones and it has medical information. But sometimes we don't look at that first. If they have a medical bracelet, whether it's bracelet or a necklace, something that tells the emergency care team, I have seizures, it can help, make the care quicker, actually. Another thing we don't think about is children who have seizures, they're kids. They're going to want to do normal stuff. They want to go out to the pool. They're going to want to swim. Well, they shouldn't do it alone. What if they have a seizure when they're out in the middle of the pool? What's going to happen if they're alone? Of course, avoid any triggers. And the most important thing that we can stress as nurses to the parents and to the child is compliance. Take the medicine. I mean, many parents are like, the kid's too drugged. I don't like it. I'm going to decrease it. And then the kid starts having seizures. These things should be discussed with a physician. Okay, cerebral palsy. Cerebral palsy is something that happens due to many different reasons. Some we don't know. Sometimes it's a malformation in the brain. Sometimes it's prenatal. Sometimes it's due to the delivery process and they had a hypoxic episode. It could be due to prematurity. Who knows all, but there's many different things. Now, how do we treat cerebral palsy? Now, there are children who have mild, that can move around and they're not so like that spastic, like they're really just can't control their muscles and their nerves, okay? That spasticity is a big deal. Now, they've learned that botulism, hitting those nerves that are really twitching, can stop it. And that can help a child maybe feed themselves without all the food going everywhere trying to get to the mouth, right? Because it can happen that way. I have a little kid who's 7 years old that I was very close with when I was doing clinicals for the college down here. And I'll never forget this little boy. His name is Jonathan. And they put him on levodopa carbidopa. We use that for Parkinsonism. Isn't Parkinsonism that really shaky thing that can happen? Well, what is cerebral palsy? That spastic. They're shaking too. They can't control their muscles. And it did a little bit with that. Now, remember always good skin care, good dental care, all right? And the one thing is, we maybe get a hand that's crooked or a foot that's crooked. Make sure that we put braces on these children so that we know to keep those joints, those legs, those muscles stretched out just the way that they should, okay? Now, these kids some of them can be up and mobile. We use braces, again, to hold their legs so they can be good. And then sometimes they're going to need surgery a little bit more. Now, what is our goal for taking care of children with cerebral palsy? Well, Jonathan was nonverbal. He couldn't talk. But he was given this little iPad and he could communicate through it. In fact, he used to get his occupational and speech therapy with this iPad, where they were teaching him circles and ovals and squares and rectangles and colors, and he could point to it, he could get his finger there and he could communicate. And just being with him, he could tell you, I love you, with a push of a button, or hello, little things. The kid was only 7. So, and remember, their minds aren't up to the level of a normal 7-year-old. So he could communicate, and he's nonverbal. He didn't even eat. He had a gastrostomy tube. So mouth was not something he really used much. You need to have him have the ability to move, get around. Now, he was stuck to a wheelchair, but at least we could move him around in a wheelchair. Maybe later on in life, he'll be able to move himself, maybe not, because he was quite severe. You do have children that have these walkers that go around them, and they can really use them and hold on to them and get around with those leg braces to keep those legs straight. We need to make sure that we get them and to be whatever they can move to be the best they can. So therapies, your physical therapy, occupational speech therapy, so important. They need to be social. They need to be around other kids. They learn how to express themselves. Kids can be 2 different languages, and they can sit there and they're talking to each other, and it's like they know what each other is saying. Well, this happens also with these type of children. So trying to get these kids to take care of themselves, brush their own teeth as possible. Maybe, Jonathan try to learn how to feed himself. I mean, he was very spastic, but allowing him opportunities to try things. Now, there are many different children, and, due to many reasons, do have some sort of cognitive delays. Remember, children that have cognitive delays, they still need to be around other kids. They still need to interact. They don't need to be separated. We are integrating cognitive delayed children within regular classrooms because it does help with their minds, and it does help them try to be more than you ever thought they could be. So with children, and the success and how to approach these intellectually impaired children. So we need to teach the parents what a child can do. We need to concentrate on strengths, not on weaknesses. Because even you think a nonverbal child with cerebral palsy doesn't know that you constantly tell them you can't do that, you can't do that. They understand. So always do those strengths, like Jonathan, what a great smile you have. Let me give you a hug. And if it's a smile, it's a smile. Or wow, you got that oval. Yes, good job. We're not going to put them down for things that they can't. Because if you're always told that you can't, you're going to be angry. And now you're going to be a difficult child. Okay? And now you're not going to want to try to do anything. So what is our goal? Our goal in management, well, when we find things that are going on with these children, and maybe we can see it at birth, maybe we see it later on, we need to let the family know what's going on and provide whatever support, emotional support, understanding. Also, you need to let these parents know what needs to be done for the child, what he's doing well, what he needs to fix, and then the things that he just doesn't know yet needs to learn. Now, if in the hospital, just because a kid's 7 doesn't mean they're 7 years old. That's why I always say, get on the developmental level of the child. We have Jonathan is 7 years old, but he's more like a 2 or 3 year old. So we describe things like that to him, okay? And then, of course, let him do as much as he can. We tell the parents, say, well, he tries to brush his teeth every day. Well, of course, we're going to continue that. And keeping them on home routines is so important. When we talk about children in the hospital, they need the family there as much as they can, or they go through all of those, grieving because of this, they're not there, right? You did your discussion questions on it. Also keep them on the same routines, and this does help with that confusion. So nursing responsibilities, again, emphasize the strength. Make sure we're talking with that family. Maybe there's something that they're not doing that another family did that you know that would help the child and it was free, let's say, or there's some program, or there's some sort of group that they can, join that can help them with their frustrations. Again, don't call these kids what they're not. Yes, they do have cerebral palsy. They're not retarded like they used to be called years ago. These children are delayed. They're cognitively delayed, but they doing so much more than they ever did before. So if a kid's cognitive delayed, as I said, they're going to go to school. And sometimes they have a caregiver go with them, depending. But again, we're going to try to put them in regular classrooms, not like that extra classroom. Because I remember when I went to school, they had those kids in another classroom. And, some of them didn't even look cognitive delayed. I always was very confused about that. Also, when you're doing things with these kids, you're always going to have something that they can succeed in. You're going to give them challenges, but they need to succeed. Like with any child, if they are not succeeding, they're not going to try. They're going to get angry and frustrated, like I said before. And of course, get them into some sort of support group. Now, the one thing that you will see is some children look perfectly normal, and some children you can sort of tell that they're not there. So again, before we assume that a child is a certain age, make sure we have some communication to determine, are they, cognitively delayed, or are these children that with normal faculties that you could speak to them on their age level? Okay. Safety alert. A concussion with resulting amnesia and confusion can be more serious than the presence of a fractured skull with no clinical findings. Now, you can be in a car accident and your head can go back and forward, and now your head has got swelling and things are going on. You can have children. My grandson just told me he hit his head and his head hurt, and he didn't go and play the game in soccer today when he was playing soccer. These children, they get hit, and when you start seeing that they have a loss of consciousness or headache that's increased in vomiting that's not related to eating, something's going on. I mean, I've had many kids come in when I worked in the ER for the last 10 years. They slid into third base, they hit the knee of the defender, and I hear, and they lost consciousness, brought to the ER for, evaluation. And the kid keeps asking, so was I safe? Was I safe? Did I make the base? Or did I win the game? Did we win? Did we win? And it'll be over and over again because they are now getting amnesia. So, complications of head injuries. Now, head injuries, can be, a headache, and then, they'll be okay. But, I've seen children with head injuries that have fallen off second-story balconies. And second-story balconies onto the head, can relate, with many different things that can go on. Now, one of the things that happens is get a head injury, you fall, there's probably going to be a little bit of bleeding going on. Where that bleeding goes on, you are going to see it lacking oxygen to an area in the brain, which is called hypoxia, okay? So that's going to create, wherever it hit in the brain, wherever that bleeding is, symptoms. You're going to see an increase in cranial pressure because there's blood in the head. It doesn't want it. And then because it's injured, it's going to swell because it's responding to the injury. And then because of it, you can get an infection because of all this extra fluid that's in there. So when we're talking about hypoxia, the brain, is trying to help itself. But what happens is it puts more blood flow in there. And more blood flow to get more oxygen is creating increase in the intracranial pressure. That's why hypoxemia, especially in the brain, is so very dangerous. So again, there's your signs and symptoms, basically what I've said. The headache, nausea, dizzy. Sometimes you get walking. You can't walk well. You get, very wobbly when you weren't. And then it goes on into fogginess, cognitive fatigue, etc. Then it goes into many different moods. And if you let it go on for a day, you're going to see them sleeping or not sleeping or both. It could be either or. Now, you've heard of shaken baby syndrome. Shaken baby syndrome is when a kid has been shaken so much that their brains have been back and forth and it's created a big injury. Shaken baby syndrome can lead to permanent brain injury or death. Now, younger kids, you really can't tell you, infants, but toddlers, they'll have that headache and you're going to see the symptoms of it, which is drowsiness, blurred vision, vomiting, and, difficulty breathing. Sometimes when you get these kids, they've been shaken so much, even older kids, they're unconscious and you really don't know what's gone on because usually a person did it to them and they're not going to say, well, I shook the kid so hard that, we went unconscious. They don't say that. Sometimes when they go unconscious, due to this thing, this brain injury, they can do these different injuries poses. And there's the corticate and the cerebral. Now, how do you remember which is out, which is in? Well, the way I've always remembered, the corticate is back to the core. I'm the core, I'm here, okay? The cerebral, it goes out to the side. Cerebral is away. So the corticate comes inside. So the cerebral has to be the other way. So observing this child, for signs of increased intracranial pressure. Well, you've fallen down, head injury. Again, what are you looking for? If you had a kid who's fallen off of a monkey bar or off of the bunk bed, you're going to do your level of consciousness. You're going to do a pupil check, take vital signs, and you're going to see, are all those body parts moving in the same fashion? Are the hands equal, feet equal, et cetera, et cetera? And there's a picture that you see. In infants, when they have a head injury, you'll have that bulging fontanelle, yeah. But the biggest thing, which is a difference, is a high-pitched cry. These kids, it's a different cry. We call it a neuro cry, and it's like nails on a chalkboard. It's not a normal child cry. Its pitch is very, very high, and you can tell something's wrong here. Once you hear it, you'll never forget it. So how do you take care of a kid who's gotten brain image, brain injured? Well, sometimes you get this kid in, they're there, they're being looked at, but what they're showing you is very subtle. Maybe it's an intermittent, or you think it's a language problem, something, and they're really just confused. You can't. So when you see a kid, can't tell or express what's going on, sometimes it's hard. Now, try to do that to an infant. The kid fell off the changing table onto its head on a cement floor. How are you going to assess neurological status on that kid? Well, if they have that high-pitched cry, of course, fontanelle is swollen, yes, of course. But if they're not, they should be able to grasp something. Those gross motor, fine motor skills, they're not doing, lifting their head up and they're 5 months old. Something's wrong. And then you'll be looking for it. There's clues. We know what kids should be able to do. So we're going to look at kids with neurological assessment. We need to look at the child and assess the kid for injuries, okay? So that pain stimulus response. I can't tell you how many times you get a kid unconscious into the ER from rescue. And of course, the doctor looks at the eyeballs. see, check it, and then they'll take their nipples and pinch them. They want to see their response to pain. Did they respond? Did they wake up and go, ow, which we want to hear? And then if they're awake, are they alert? Do they know where they were? Do they know what happened? And then as they're asleep and waking, do they know what's happening? And then you look at the cranial nerves. The cranial nerves is going to tell you where that head was injured. Maybe you see a big bruise there, and it was, on the area where is something to do with your speech. And okay, they're speaking good, so we're okay. Are they posturing? Decerebrate, decorticate, and then pupils. Remember, a dilated pupil, you're in trouble. Neurological emergency, and that needs immediate surgical intervention. Of course, an infant, bulging fontanelles, those scalp veins will pop out, or a kid's walking and all of a sudden they come very spastic on their legs, wobbly, or that really stiff thing. And then, of course, any of these withdrawal reflexes. Does any of you have a pool at home and you have kids and you worry about children? Near drowning is something that happens quite a bit, more than I'd like to tell you about. I've seen it happen to physicians' children, and I have a pool in my backyard. Now, the one thing that I did do when I had my grandson living with me for the first 3 years of life, by the age of 6 months, this kid was in the water with his swimmies. Then by the age of 1.5, swimmies were off and he learned how to swim. He knew he was jumping in, front ways, backwards, he didn't care. He knew where the sides of the pools were. He knew how to float on his back. By 2.5 years old, this kid was doing front flips in the water. Now, does that mean I let this kid go in the water whenever he wants by himself? Oh, that kid will not even go near that pool without asking first, because he knows it's dangerous and he knows that he could die. So the reason is because of what I'm going to tell you now. When you have a drowning, and look at this, 4th leading cause of death in children under 19, that is a lot of drownings, okay? I mean, I live in South Florida, so I'm around ocean, pools, water everywhere. We know that near drowning is you've gone underwater, you've aspirated this water, you've been hypoxic, and you probably have lowered your body temperatures. Not many pools are at 98 degrees. They're usually 90 and under, right? So that is hypothermia for us. Now, sometimes we go, we get these kids, medical rescue comes, and the kid, we've already got the kid out from the bottom. Somebody did a CPR or, pushed his back and he puked and vomited, and now the kid's fine. Oh, he's fine. And no, he's not. Because you can have a hypoxic episode and respiratory distress up to 72 hours later, which is crazy. And we know that this hypoxia thing that goes on with these kids, depending on how long they're down there, can cause death, and it can cause a lot more things. The thing says for underwater for 10 minutes with failure to regain consciousness at scene or within 24 hours is an ominous sign and indicates severe neurological deficits if the child survives. And many of these kids, they declare brain dead because there's no brain motion, or these children are going to end up basically a child, which they're not there anymore, and that's what the one that happened to the physician that I remembered. He had this 3-year-old went in the pool. He found him on the bottom, and it's really sad. It breaks your heart. So let's go to chapter 24. Let's go into musculoskeletal. You can have club feet, right? Remember I told you CP, they have these walkers that work great. They actually turn the adult walkers around, make them wider, and they can get around and they can walk pretty cool with them. So we have objectives. So musculoskeletal, what you need to know about the musculoskeletal system is that children end up having these bones that are not completely ossified yet. And when they're not ossified, they don't crack and break as easy as adults do. Now, they sort of bend. And we know muscles, whatnot, is used to move around, etc. So when we're evaluating, these children, we are looking at how are they walking. Now, an infant is not going to walk normally. They're going to be wobbly. They're not as coordinated. But by the time they get older, they're going to be able to walk, more, gracefully, per se. Now, they say a child who cannot walk independently by 18 months of age has a serious delay and should be referred to for follow-up. Now, with that being said, all my children never walked until 15 months, and then they ran. They did have a couple steps going on. Everything else was normal, okay? But they never walked, they ran. So again, it's looking at the whole pictures with this. Now, the musculoskeletal system in children, the biggest concern is where the breaks happen. Well, think about children. Well, look at the infant. In the first 6 months of life, they gain 1 inch a month of height. That's a lot of growing really quick. Also, look at that pre-adolescent growth spurt where they gain 20 to 25% of their weight, really quick. So they're growing fast. Now, put a break somewhere there. But put that break in the growth plate where the bones, that's where they grow, and you don't fix it properly. You can have a crooked arm, a crooked leg, or a shorter arm or a shorter leg. So the epiphyseal plate fractures is an extremely important fracture that we fix correctly. They usually do surgery, an open reduction, internal fixation. Like I said, young kids, they're walking this wide, unstable gait. By 18 months, it's becoming more stable. They're walking a little wide, but it's not as wide. By 4 years old, they're starting to hop on 1 foot and their arms starting to move as they walk. And by 6 years old, it's just like an adult. They're walking and their arms are swinging. So children, when we're looking at their gait, some parents are concerned because they look funny or they're wobbling or they're a little delayed. Number one, if a kid is normal, not in pain, fine, these movements should be correcting by themselves, as in spontaneously will resolve, and they'll be able to catch up with the other kids. And we know if not, we're going to order sort of therapy on them. So looking at muscle tone, sometimes kids, there's diagnoses, muscle tone. Well, look at the Downs child that they can put their legs behind their head, their muscle tone, and they're just so hypotonic, right? And there's other kids like cerebral palsy that are spastic that you can't move because they're tense. So you're going to see all different sort of muscle tones. So keeping that in mind, then you have to do your neuro assessment and looking at those reflexes and see basically where that kid's at. I mean, we've got all of these different sort of reflexes that we look at. Neurologically, fine motor skills, that's all neuro. But remember, it uses the muscular system to do those neural assessments. Can they do the palmar grasp voluntarily? Can they do a panther grasp? Can they walk? Can they limp, etc.? So when we see different things going on with children, what do? How do we identify? Well, sometimes kids have these limps for no reason, and we're going to go into some of the reasons as we keep going, but we are going to do, depending, could be just an x-ray, or we could do CTs, MRIs, ultrasounds, bone scans, depending on what the child needs, not necessarily all of them. Now, we are going to be doing a CBC. Now, why would we do a CBC on maybe something, a limp going on with a child? Well, we're actually looking for an infectious process. Maybe it's something we missed. There's an elevated weight count, you got an infection going on. Now, does anybody know what an ESR is? An ESR, what is it?
It's something with sedimentation rates, right?
It's yeah, but let me tell you what it's all about.
Inflammation. Right?
Inflammation. So if you have a child who's not walking, limping, and you do a sedimentation rate, an ESR, you are looking at inflammation somewhere. So that's telling you, yes, something's going on. And this can tell you, is it like juvenile idiopathic arthritis? Because it could be, or is it an infection? The SED rate is high and the white count is low, it's probably that arthritis. And if it's the white count elevated, SED rate elevated, that's probably the infection, the osteomyelitis. So these laboratory tests, we do both to try to figure out what's going on here. There are all different tests that we can do to look at rheumatological disorders. I'm telling you, they're still looking for good ones to diagnose, like the JIA. So treatments for musculoskeletal. Well, an arthroscopy, I think most of the time I've ever heard of this is for a knee. They take a scope, go into the knee because you have a torn meniscus. They go in, they look at it, diagnose it, and they treat it. And it helps, repair that joint, that tendon, that meniscus. Excuse me. Sometimes we can have tumors on the bone, and we're going to talk about it later, called an osteosarcoma. And the diagnosis is made because the child is going to be limping, causing pain, and it gets worse and worse as this tumor grows. And what they do is they'll go into the bone and take a little piece of it, and they'll look at it, and they'll see that it's a tumor, which is highly metastasized if we don't catch it quick. We're going to go into tractions. Traction is a very important thing with musculoskeletal. We use this a lot in children with dislocated hips at birth, that continuum, or we can use it for fractured femurs. It pulls that bone out to stop the pain because the muscles get tight and those little sharp edge of bones just pull against each other, and it causes a lot of muscle spasms and pain. So you pull it out and it goes straight, and the pain and the muscle spasms go away. And of course, I don't know if you've had a cast before, but we know it to immobilize, or sometimes you have a sprain, they'll put a splint on you. So how do you treat a soft tissue injury? Some sort of ecchymotic area, a sprain, a strain, one of those. Well, number one, you're going to rest it. Stop. You're not going to walk on it. Ice it, compress it, and elevate it. I was always in sports and volleyball, and I'd go spike the ball, come down, and my foot would go wrong, and I would really kill my ankle, as I called it. And the first thing I would do is stick my foot right up in the air because I could feel it swelling as we sat there. And of course, they come out with the ice, put it on there, put an ACE bandage, and then of course, get me off the floor and replace me. But RICE, I love that acronym: rest, ice, compress, and elevate. As I said, treat it immediately. The best way that you can help it get better is to do what I did. Get it up in the air, ice it and elevate it, contain it, keep it from getting any bigger. And if we could prevent kids from getting injuries, we would. But, we can't always do that. Kids are going to do what they want to do. More safety issues, car seat restraints. We know that a kid needs to be in the back seat, rear facing, up to 2 years old or 30 pounds. Then you can, at 2 years old, put them rear seat, put them front facing, and they're recommending these car seats to be put in the middle of the car. I mean, go around and look at cars with car seats, and you're going to see them by the windows, all of them. It's just something that's been done. It's not changed, but it's where they're safest. When you get hit from the sides, you can't get the kid. Today, it's mandatory for kids to wear bike helmets. And remember, any sports these kids do, they really need to use protective gear. It prevents a lot of accidents. You know, those little hoverboards, whatever they're called, that came out. You know, I saw 2 bilateral, both hands, bilateral fractures, both bones, because they didn't have any wrist protectors on. Wrist protectors could have saved these children bilateral fractured wrists. I mean, both of their hands were gone. I can't even imagine spending that time in casts like that. Pool fences, I can't highly stress that enough. That's now a requirement. You buy a house with a pool, you better put a fence around it because it's a part of the insurances. Window bars, well, window bars do protect you, but what about a fire? So they can be a problem. And I know that regular windows should be locked in a manner that the kids can't get out of them. I actually had my oldest son go to the window, pull off the screen, and it was one of those jealousy rolling windows here in Florida. And he got out, and my husband was home, and he heard the dog barking, which were very vicious Dobermans on the next door neighbor. And the grandmother who lived there saying, "Oh, you're such a bad boy. What are you doing here?" He had gotten out the window. And we lived right next to one house over from a very busy street. So again, windows. Deadbolt locks, make sure those locks are up tall so they can't reach them and can't get out. And of course, anything that's dangerous should be behind a locked door, medicines or any of your household cleaning stuff. Now, different type of fractures. Let's go into some of them. Well, a green stick fracture is an incomplete fracture, but you can see that almost done there. Do you see that? Where it's gone through, but not completely. Now, the one I want to mention here, let me see where it's at. Spiral fractures up top there. When you see a kid having a spiral fracture, always think about child abuse, okay? Because it has to be twisted. So the kid's trying to run and your kid's trying to twist you back. So they take your arm and twist it back. And that's usually, you're going to see that in child abuse. So even types of bone fractures that you have to be concerned about because they do mean different things. You know, remember, fractures do need to be casted. They need to be immobilized to keep them moving the way that they should. And either they go to surgery, get a cast surgery, or they get some sort of traction. So a fracture is a break in bone. Children will come in and they'll be complaining of pain and swelling. They can't move it. It hurts. Sometimes you see bruising. Now, the neatest thing about children is infants, young children's bones will heal in 2 weeks. 2 weeks, that's it. And their bone is fine. Young children, 4 weeks. That's why they get a cast on the beginning of summer. They still have the other half of summer to play because, yeah, it's the beginning of summer break. And look, he's in a cast. Well, it's going to be only 4 weeks and they usually take them off because, again, these bones are more flexible, they're less brittle, and they heal a lot better. Now, let's look at a kid who has a fractured femur. Now, there's 2 sorts of fractures with femurs, type of tractions that we use. Now, the younger kids that are less than 15 to 18 kilograms will be placed in Bryant traction. Remember, that femur is broke. And if we don't keep them together, those points are going to hit those nerves and those muscles, and it hurts. And you have really bad muscle spasms. So you pull it out and their butt's off the bed a little bit, and it keeps them straight. So now it's stopping the pain on them. Now, sometimes you got to put them in a restraint to keep their body straight so that the legs heal straight. But this is a good thing. In older children, we'll put bucks traction, which is just that pulling of that lower leg. So let's look at traction. What do we need to know about it? Because it's done in the hospital. Any kid who's in traction has a fracture. That fracture can cause swelling, can cause bleeding, and if we're not careful, this swelling and bleeding could occlude blood vessels. So you will be checking as much as possible the neurovascular signs. You'll be doing that every time you walk in the door, feeling that pulse or feeling the capillary refill, making sure that leg is good, because it can, just the swelling can occlude blood vessels. And then, of course, now you're worried about maybe you're going to lose a foot or a leg or a toe or something. So we want to make sure the blood's going. Now, traction always has a rope, and it goes down to a pulley to a weight. That weight is on 24 hours a day. It's never to be taken off, because you got your femur like this, you take it off, it's going to pull it off, and now you're going to go back to where you were, and it's painful again. Another thing is, remember, children that are on traction are going to be in bed rest. Prevent all of those things that can happen. Respiratory complications, blood clots. Also be concerned about urinary retention, bowel problems. They have to pee in a bedpan or in a urinal. And a lot of these kids, they don't want to do that. They're shy. So you have to be careful of those things. And then we need to keep those other extremities, strong, especially the arms, okay? So put a trapeze and they can do exercises. They can do pull-ups on them. Keep those arms good. So bucks traction. You've got Bryant traction for those young kids, okay? Less than like 18 kilograms. If they're older and larger than that, we're going to be using bucks traction. And you could see the Bryant is in the air. Bucks just pulls it straight ahead, okay? And it's skin traction. There's nothing that enters these bones here. Again, it goes down to a pulley, down to a weight. So what is the things that we need to be concerned about? Nursing care. Well, you need to keep that foot off the end of the bed, because now it's not pulling. And you must help that child pull up in bed, because they can't. They've got this broken leg bone, and they've got this weight on the end. They can't pull. It hurts. So you have to assist them up in bed, okay? Another thing, never have the head of the bed up very high. Only can be about 20%. It decreases the pull of the traction, okay? Now, there's another thing like your bucks traction, but it adds the little sling there. And that little sling just holds around the knee. And it's 2 pulleys of weights, okay? So it pulls in 2 directions. Again, it's similar, same sort of things as bucks. You keep those weights free hanging. You're going to chart the weight, and they're free hanging on your nurse's notes to say that you checked it and how much weight is on there, okay? So this is all about the pictures, all about what I just said. So again, weights are free hanging. They shouldn't be anywhere where a kid can touch them. If a child comes in, make sure the parents know to leave it alone, leave those ropes alone. And that this kid, you can't be adjusting the bed or anything, especially the head of the bed. So making sure that, again, that you have enough space between the end of the bed and the weights, and it's pulling right, and they are proper position, head of bed's not too high. All of these things are important. Now, sometimes just skeletal skin traction doesn't work. pulling with putting like a little boot and an ace bandage, and we could pull it very nicely with a fractured femur. But sometimes we need an external device. And these external devices are these metal things, and pins go directly through the skin into bones. And they're used for more complicated type of fractures. They actually use these if once you have one leg longer than the other, they will break the bone and break it apart to try to get that child to gain that inch or two. So they won't have 1 inch difference in their length of one leg to another. Your job is those pins are through the skin into a bone. Meticulous pin care, okay? And the pin care is the way the doctor says. They all say different. So whatever that pin care is, and documenting the skin at the pin site is clean and, not any debris. So again, this is all about those things I told you about, what you need to do for these children. Now, if a child goes home on a Buck's traction, and there are some conditions that they would, school needs to provide them with schoolwork, very important. And then of course, making sure no blood clots, no breakdown in tissue. I mean, they're in bed rest. They could get redness on their buttocks or their bony prominences. Making sure they use incentive spirometry, and they're going to exercise what they can. Making sure that their bowels are moving and their urine also, because they'll hold their bowels. I mean, children can hold their bowels longer than you can imagine. I've seen it up to 12 days with no stool. And it's the way that they are asking for help, believe it or not. We'll go into that when we get to GI. So, checklist. Body should be in alignment. Head's no higher than 20 degrees. The heels of the feet should be elevated up, but shouldn't be at the end of the bed. You should have range of motion for all those parts. And the exercise, wiggling the toes. Anti-embolism stockings, talking about blood clots. Always check those neurovascular signs and make sure you document them. Skin integrity, how's their butt? Is it red? Do you need to rub it? What do you need to do to help it? Pain. Now, you have a fractured femur, you're gonna have some swelling, it's gonna hurt. Make sure we give pain medicine. But again, pain medicine causes constipation too, doesn't it? So again, do everything you can to prevent constipation. And that trapeze is great. And let that kid lift themselves up and move themselves slightly, which is what we want to do for problems with skin integrity. So when you do a neurovascular assessment, what are you going to check? Well, do they have pain? Now, this is something you're going to tell parents going home with a child in a cast also. This isn't only just for you in a hospital where you're checking a child in traction or whatever. You are going to be teaching this. So if you have pain that's getting worse and it's not handled with the medicine they give you and it's getting worse, that's one. Now, if there's an area where you can feel a pulse and now that pulse is getting weaker or non-existent, that's a problem. And usually with that, you're going to see that pink hand or foot or toes becoming white, okay, paler, okay? And then all of a sudden it's going to be numb and then you can't move it. So these 5 Ps, if we're seeing it, this is an emergency. This could be considered compartment syndrome, and it requires that cast from being taken off, okay? So peripheral pulses, the color, capillary refill, warmth, movement, these need to be reported immediately. We can check nerve things. There's ways to do it. So again, you have a child who's in sort of any cast, remember, there's going to be some issues with skin integrity, making sure that we do everything we can to decrease that. That compartment syndrome is when the cast is getting small and the swelling's going on and now you don't have any blood supply. And you'll see all those 5 Ps are the worst way that they can be. So if we do not get that cast off and allow blood flow, they could lose the entire arm. Okay, it can be that serious. I've seen pictures of it. I never seen one, but it can happen. So you have a child sent home, going to be on a cast. Make sure that we keep that whatever, arm, foot, leg elevated 72 hours, up on at least one pillow. Teach them and the parents how to do neurovascular signs, how to push the little toe. You know, it goes white and then it goes pink. How many seconds did it take? Okay. And then cast care. You can't get these casts wet. You get a cast wet, it needs to come in and it needs to be changed, because if it's wet underneath, it could lead to bacteria and fungus growing underneath the cast, and that can create even more problems. Now you've got an infection going on. Again, nothing down in the cast. Using just a cool hair dryer can help when they get home. And again, if their cast is too tight or even too loose, they need to contact the physician or get back to the hospital where they put it on. And if this child needs crutches, making sure they know how to use them and how to be using them safely. You know, kids like to be speed demons. You know, they like to haul butt down the hall, right? Boom, boom, boom. And they could go forward on their face, and now they got the broken nose along with the broken foot, right? It can happen. I've seen kids take off and fall flat on their faces. So seen it happen. Another thing is osteomyelitis. Now, osteomyelitis is an infection that can get into the bone. Now, when it gets into the bone, it's an extremely infectious thing where they need to get treatment. Now, osteomyelitis can occur in children younger than 1 or usually 5 to 14. I've seen them in toes a lot, hands a lot, where they got pinched or they stepped on something. And what happens is they step, you know, let's say they stepped on something and that stuff got in the skin and then it went in and it attacked the bone. Many of the times it's staph, and they'll complain of pain, swelling, and even you get a fever. You know, these children will require antibiotics. They usually will give them IV antibiotics for a long course of time to get rid of it, because it is quite serious. Now, another time osteomyelitis is like alert, right, and will start treatment immediately, is if you have a fracture where that bone comes out of the skin. Now it's the bone has been touched the environment. So now you've got to consider that it's going to be an infection. So this child will get antibiotics, an open fracture. It's also called a compound fracture, open or compound. So what happens with osteomyelitis, you've got this, let's say it's your thumb, and something stuck it, and then the infection went in. Now your thumb swelled and red, and you've been diagnosed osteomyelitis. What happens is all of that swelling and oozing all this pus that goes in there can cause this finger or part of this finger to die, become necrotic. And it got a lot of pressure in there. And it's actually even the little muscles of the thumb, you can feel them spasming, you know, and because it's so swollen, it's hard to move it around. So this is part of it. So you think it's osteomyelitis, but you know, you never had a fractured with an open bone. You know, you just hit your finger, you pinched it with something, and you think maybe it's just a cellulitis. Well, how are you going to know the difference, right? Well, you're going to do an X-ray, and you're really not going to see much, really. It's sometimes you see a little fuzzy haze, most of the time not. But you're going to see a white blood cell elevated. That's an infection, an itis. Any itis is an infection. And the ESR, which is your SED rate, shows that inflammation, okay? They do sometimes say, all right, let's go ahead and make an accurate diagnosis. Let's do a bone scan. And if there's an infection there, it's going to light up like a Christmas tree on a bone scan. So again, IV antibiotics, several weeks. It could be 4, 6, 8 weeks. It could be quite a long time. Sometimes they'll decide, let's just go in, open up and get that pus away because it's so swollen and so painful. Sometimes yes, sometimes no, depending. And of course, we are going to work about pain, and then pain relief, remember, is not all about just all the antibiotics and the pain medicine we're given. Remember, children with this osteomyelitis, many times with the IV will be kept at home. You know, give them something to do. Put their mind somewhere else. We have them, you know, use their iPad or their computers, or do a game, or watch a movie, or listen to music. Because pain medicine alone works, but you put that diversion in there, it makes them think less about pain. And I think that's pretty cool. And because it is a bone, as we can, physical therapy to keep the motion in there so we don't lose that. So now we're going to talk about something called muscular dystrophy. The most tested diagnosis that you see, and it's the most common, you see these on the HESI, NCLEX all the time. They love Duchenne muscular dystrophy. It is a muscular dystrophy where the child is born and they're going to be delayed. It's usually a boy, ages 2 to 6. And you see a little bit of motor development delay, cognitive delay, but you don't have an answer yet. Well, about that 2 to 7 or 6 years old, they were doing okay, delayed, but all of a sudden they start falling over. They start being more clumsy, and you start seeing these contractures of ankles and hips. Now, the other thing you see with them is just like an old lady, like me. I get on the floor and I try to get up. I will take and put my hands on my legs to climb up my legs to stand up. That's called Gower's sign. These kids do it. I mean, they're 2 to 6 years old. They shouldn't need to have to do that yet, right? As I said, they do have some intellectual impairment. These kids, you will see different things going on with them, but it's usually the biopsy. And they'll do something called an electromyogram, and it shows how quickly you respond to a flash of electricity. You know, do you respond quickly or do you over-respond? And that is going to give you the diagnosis of muscular dystrophy. Now, muscular dystrophy comes from mommy. And usually what happens is it's a muscle, just like Becker's is another one very much, but it's a little slower from it. But Duchenne is aggressive. These children are needed to be in aggressive physical therapy to keep their muscles moving. They're going to end up in wheelchairs because they're not going to be able to walk. And then their heart muscle stops or their diaphragm muscle stops. And usually it's that teenage years and they die because their muscles just stop. So nursing care is supportive. There's nothing, we can't treat it. There's no magical thing we can do. We just keep them as limber muscles, as you know, as flexible as possible, so that they can at least get in wheelchairs and be up and around. Yes, they are cognitively delayed, but you don't want them stuck in a bed. You want them up and out because they do get depressed because they can't be around all of their friends. Another thing, and some very similar comes up next, is called coxavera. And what happens is the end of the femur that goes into the hip joint slips. So it's not in the right place. So when you try to walk, it's not in the right place and smooth and movable. It hurts. It is not related to trauma at all. Many times, this is during that time at pre-adolescent where they have this massive growth spurt. They grow 20 to 25% of their total weight within 2 to 3 years. So it's a lot of growth really quick. It's like the infants in the beginning, quick. Well, these adolescents, same thing, really, really quick. What do they see? Well, it's going to hurt, because it's not in the right place. Their muscles are stretched. It's not sitting right, and they're going to be limping. And it's going to be to the point where they can't bear weight on it. How do we treat it? Well, we want to put that hip joint back where it should. So we put them on that buck's traction. They're big, they're pre-adolescent, they're 12, 13-year-olds. We're going to put it in place by pulling it. So we're going to give them, for pain, just some ibuprofen. Or we're going to give them, again, the buck's traction and keep them at home until we get it where it needs to go. Now, another one, which I told you just like that, is called leg calf perth disease. And this is an aseptic infection of the hip joint, which is due to a disruption of blood for no reason at all. It just happens, okay? It happens in boys ages 5 to 12. And again, the same sort of feeling. They're limping, they're in pain, it hurts. And these children have this, this like necrotic area because of no blood. I mean, they can end up having arthritis as adults because of this. So again, with these, we put them on buck's traction and we give them their ibuprofen, and the kids actually do good. Rarely do they need to have any joint replacement at all. It is just bed rest, okay? Bed rest, on the x-ray, you see the white fuzzy, the head of the femur, it looks all white and fuzzy. It should be really brisk and a sharp edge, and you see fuzziness, and you say, oh, that's what's going on, and that's the blood supply. Again, heals spontaneously. So put them on those buck's traction, bed rest, and they'll come along. Now, I mentioned earlier about a bone tumor and something called osteosarcoma. Well, osteosarcoma is a very cancerous type of cancer that is on the femur bone, and it's usually your kids age 10 to 15, a lot of boys, okay? What they do is they have radiation therapy. They're saying some of these kids had retinoblastoma. There's some correlation that if you have retinoblastoma, this could happen too. But what they do is, number one, they're going to check you for metastasis, and lungs are where they see it the most. And what they do is these children will complain as pain and limping. This is all the thing with bones and, the legs or the hips. You always see pain and limping, that gets worse, or sometimes worse in the morning. These are things you see. Well, this is the one that you're going to do the biopsy. I mean, if you can see that thing sticking out, or the two things come together, the thing that's sticking out, that's your bone tumor there. That's not right. It should be smooth the whole way. And there's actually some on the other side. So how do we treat this? We've done the x-ray, we see it. We've done the biopsy, we see the cancer cells. What are we going to do? Well, we have to take the whole femur out. The whole bone has to be removed, okay? Now, with any amputation, there's phantom pain because the nerves are still there and they don't realize they don't go to anywhere, but they're still there. So it's quite a thing that these children suffer with. Today's treatment, they literally, and sounds crazy, but they take the lower leg and they put it up where the femur was. So now there's sort of a stump, because without it, there's nothing. There's nothing to put a prosthesis to walk. So now they do something called salvaging the limb. And these children now have a place to put a prosthesis and they're able to be more mobile. So I think that's a pretty cool thing that they're doing now. I'm just telling you that because I know that's what's going on. I've seen a couple of kids and, you know, they do well. They learn to deal with what they have and having a prosthesis, and they're normal in every different way, every other way. Now, Ewing sarcoma is a malignant growth of bone that comes from a tumor in a bone again. But I've seen these things in a scapula. I've seen it in a jaw. And again, these kids need radiation therapy and chemo. Again, it can metastasize. Of course, if it's already metastasized, these kids, you know, have a really poor diagnosis. And then they really need to remove that tumor to get rid of those cells in there. Now, I've mentioned off and on a little bit about juvenile idiopathic arthritis. This is an autoimmune disease. An autoimmune disease involving the joints, connective tissues, and the viscera, which that's why some abdominal pain sometimes can be there. They are the opposite to JRA, or juvenile rheumatoid arthritis, is lupus, another immune disease where the body attacks organs. But JIA, or juvenile rheumatoid arthritis, is joints, not any of the organs. So they're very similar in the treatment, etc. There's no cure for this. Now, I'm an adult and I have juvenile rheumatoid arthritis. So I understand the plight of the children that come in that are telling you and it hurts. And in the morning, it's, you know, more painful because it's stiff. We know that if a kid has, you know, stiffness, and could be a hip, could be a knee, could be a wrist, an elbow, a shoulder, a finger, a toe, an ankle, could be anywhere. And if it's lasting a long time, not going away, then you're going to be suspicious for it. Again, that was the assessment, is when it lasts longer than it should. There really is not any test or cure for this, okay? It's very difficult to diagnose. Just, you know, just to let you know, it took almost 10 years to diagnose me. And I'm a nurse and I know what's going on, and nobody would listen. So finally, I found someone who said, oh, there's this new test out, let's try it. And it was like off the chart bad. He's like, yes, you do. I believe you now. I'm like, thanks a lot. I've been suffering for a few years here now. Now, JIA has different types of arthritis, okay? So there's systemic, there's polyarticular, and articular. Now, systemic, what do you see in systemic JIA? Well, it's young kids, and you'll see young kids, age 2, complaining, you know, of these things. You're going to see a kid come in who has fevers, and big fevers, 103, and they last 10 days, and they can't figure out why. They do flu tests, strep tests, you know, they look at their ears, they can't find it. They don't know what's going on. And they're going to see a rash, and they're going to think it's so many other different things. And then they remember the visceral, it attacks the viscera, so abdominal pain. Now, this kid is going to have an elevated SED rate and something called a C-reactive protein. They're both showing you inflammation, same thing, okay? So now you have 2 different tests saying my SED rate's elevated and my CRP's elevated, something's going on. And now we know it's an inflammation. Usually your white count is not elevated with this. Now, polyarticular is 5 or more joints, usually in the hands and feet. Now, when you have swelling from arthritis, this JIA or JRA, whatever you want to call it, it's warm, it's hot, and it's tender, and it hurts. And it is a lot more in girls than it is in boys that you see. And how do we treat this? Well, we treat it with NSAIDs. We treat the pain and we exercise, making sure that we keep these kids moving. They can be in activities, they can be in sports. It doesn't stop them at all. In fact, they recommend that the kids are moving. Now, one of the things that we do see and children, adults, and the likes, is that sometimes, and why we should get actually yearly eye exams, is iridociclicus. Now, this is the iris gets inflamed in the eye and eye pain, and it's due to the arthritis. So when you see an eye that's red or painful, photophobia, doesn't see right, or these unequal type of pupils, it's something that needs to be investigated. So the paltic articular is less than those joints as it was with the poly, okay? That's the difference. And again, these are the bigger joints. This is the hips, the knees, the ankles, the elbows. It's exactly all the places mine hurt the most. Again, our goal, okay, we're going to give those NSAIDs, right? It reduces that pain, and it helps with movement. You know, swelling, you put heat, you put cold, you exercise. Stretching is great. Going into the pool as much as possible is what I do. And, you know, kids too. And it really helps. Just get them moving. Put them in, you know, gymboree with the, you know, even the younger kids, because they're sometimes 2 years old. It helps them moving. It helps preserve joint function. It helps promote growth, development. And again, this is not going away. This kid is going to need treatment. You know, once they decide that it is JIA, they put them on treatment. And all right, we got them something for pain already, but they put these children on either oral or sub-Q methotrexate. And that's usually weekly. If that doesn't work good enough, there's all sorts of rheumatoid sort of medicines, but they mostly put them on the DMARDs to start with, the biologics. Ever hear of Humira? It's always on the TV. Humira, Enbrel, they start there, which is usually a monthly injection. And that stops the body from attacking the joints. That's the goal with it. And that's hopefully that we prevent, you know, that debilitating fingers in all different directions or toes, whatever, you know, trying to promote that this child is not going to end up in a wheelchair, basically. So we know that there's going to be good times, you feel great. And then there's going to be times where you cannot even move your butt over in the bed to turn over. I mean, and I've been there. It hurts. And you can't get out of bed. You can't sit up. You can't lay down. You can't even brush your hair. I mean, it gets that debilitating. So if a kid is telling you they have this and they hurt, trust me, they're telling you it hurts more than they're telling you, because it is miserable, okay? So sometimes family don't understand that this is something that hurts a lot. Remember, your job as a nurse in pediatrics is to advocate for the child. Make that family understands all the things that this kid's going through. Torticollis is that neck, you know, stiff neck to the side. You can be born with it, which goes away about 6 months. Or remember, they pull this kid by the head out of the birth canal, right? That could happen there. Sometimes they have the hips and the neck going on together. We know that exercise, heat, physical therapy, as I said, by 6 months it can go away. And we know sometimes you just sleep wrong on a pillow and it can cause it. And now scoliosis. This is this all the way to the right, S curvature of the spine. You know, the one in the middle, that's your humpback, as I call it. And then the one here to the left is that lumbar spine inward called lordosis. And the one we're going to discuss is that scoliosis, most common thing that we do see. It could be due to poor posture, and it could be due to the way that the spine is, and it creates it to go even more and more. You will see a hip up and you'll see a shoulder up. You know, you bend them over and you'll see them crooked, you know, look at their spine on their back. So how do we take care of this? Now, scoliosis, if it gets too far in a degrees of curvature, it occludes, the lungs are here. So it pushes over on one. So it stops that one lung from breathing as well as it should. So we have to correct it. Well, less than 40, we are definitely going to try to put them on a brace. And there's a picture of one now. You wear it 23 hours a day. You wear a t-shirt underneath, you put on the brace, and you're taught how to exercise to strengthen the muscles. If not, they'll do a spinal fusion and trying to get that spine as straight as they can. It'll never be perfect, but it will be the best it can be. Sports injuries, kids love competition. Kids love to play sports. Just like my grandson today, he bopped his head. Well, he didn't get a concussion, but he said it burnt there on the top. So we'll be watching him for any headaches and vomiting tonight, but he looks fine. He already ate a cupcake. We know that we have balls thrown at us, hit us, we hit knees, sprains, strains, muscle cramps, shin splints. These are all things that happen. It's in all of these sports: gymnastics, wrestling, soccer, hockey, basketball, volleyball, running, ski boarding. I mean, all of these things, you're really putting your body, doing a lot to it for a short period of time, short spurts of running, etc. And it can have problems with that. And the last thing I want to talk to you about is child abuse. And I'm going to talk to you about things and family violence. Now, as nurses, your job is to protect your child, okay? I've had child abuse cases. There's 2 in particular that I'll never forget. And I really wanted to hit some parents. I was so angry, but that's not my job. My job isn't to get angry. My job is to protect the child, which is exactly what I did in both cases, okay? We know that there's all sorts of abuse, right? We have spousal child abuse. We have neglect, which means that they're not getting food, shelter, medical care, clothing, all right? And then there's maltreatment when they're treated poorly. What are triggers? What can cause this in a family? Well, dad just lost his job. There's no money in the house. Maybe they were abused as a child themselves and they don't know any other way. Or, maybe they're abused, or maybe there is a household that has drugs in it or alcohol, some sort of abuse going on like that. Those can cause it. There's different sort of abuses: emotional abuse, emotional neglect, sexual abuse, physical neglect and abuse. Now, emotional abuse is somebody's told, you're stupid, you're dumb, you can't do that, why are you trying? I mean, if you're told that enough, you're going to believe it. Emotional neglect, they're not hugging and kissing you. You're there, but you're not. Sexual abuse, I've seen it from a couple months old up to teenagers. It happens. Physical neglect, they didn't get their needs. So one that I can tell you about was a 7-year-old boy that the father locked him in a room, tied to a bed with no food for I don't even know how long. The kid came in, no fat on him. His eyeballs were sunken in his head. You could see his hip bones, concave abs. It was horrible. That kid made it, thank God. But it will remain with me. And of course, you'll see physical abuse and you'll see all different levels of that. So again, any nurse, you can report it. This is part of your job. What did I do when I thought this happened? I went to my charge nurse, I went to the charge doctor, and I let them know. You always need to know what are your laws, and your Florida Nurse Practice Act has all the information you want, and it's so easily accessible. If you suspect child abuse, you can anonymously, report it, okay? And those people, the Child Protective Services, has to go visit that parent and make a viewing, seeing what's going on, okay? So it is serious, and they do take it serious because child abuse shouldn't happen. Now, this kid who wasn't fed, who came to the hospital literally coded for a half hour, We did get him back. His electrolytes, I don't even know how he was alive with what was going on. 1 month later, he came down to the ER to visit us and just to tell us thank you. Well, we did separate him from everything that had to do with the family, the father, everything, got a new name, he's fine. But is he fine here? Can you imagine 7 years old, remember being tied to a bed, not eating, almost dying? He took his last breath as he brought this father, brought him into the ER. And we picked him up and ran into the trauma room. That's how serious it was, okay? Where's his head gonna be? So therapy's needed like crazy. Anxiety reducing techniques, manage their feelings, let them be able to share what they're feeling, you know, to be assertive, to say no, and to tell people what's going on if possible, you know, problem solving skills, be invaluable to themselves, that they're important people, you know, and how to cope with it. It's not cool at all. Remember, there's all different signs of child abuse. I had a 3-month-old baby who came in with like this yellow-green sort of colored lump behind the ear. And when I picked the kid up to weigh it, my finger went in, so I knew it was fractured. And immediately I said, oh my God, yeah, I think this is abuse. Told the doctor, we did x-rays, we found a fractured femur, fractured ribs, fractured humerus, all different levels of healing. It happens. It does happen, and it's not pretty. Now, it was the father who did that one, and the father is no longer in the picture, and it was a twin, and the twin had the same thing at home. Now, how do we know when this abuse happened? This is an important slide, okay? You'll see it swollen and tender at day 1. 0 to 5 will be red or purple. Then it starts changing colors, 5 to 7 green, 7 to 10 yellow, and 10 to 14 brown. So that green yellow that I saw, that was a week ago that this happened. That this poor kid was living with a fractured skull. I can't even imagine. Now, remember, when you're talking to parents and you are suspecting abuse, remember there are cultural practices. For instance, ever hear of the Vietnamese doing cupping? You have pain in the back. They'll take and they'll put like the fire and stick it on the back, and you'll see these round suck marks where they trying to eliminate pain. Or they'll take pennies and they'll roll it up and down areas. It looks like abuse, but it's not. So asking, how did the kid get this? And they probably will tell you. Okay, now always ask things like that, or, you know, get somebody in there who may be of that culture to say, what do you think about this? Okay, because again, your job is to protect that child. So any questions? It's a heavy topic tonight. So you guys want to do your quiz and go home? I will send you the Kahoots, okay? Actually, I have 2 Kahoots that I'm going to send you. They'll be yours. So, you know, this lecture ran over. There's so much information to give you. Remember, tomorrow at 10 a.m., you have your next live review if you want to go with Professor Brunel. And I will be sending that recording as soon as I get it. I'm also going to be posting the Kahoots in the same announcement. So I don't like to put an announcement, make another one, make another one. It says exam 2, recordings and study guides. It's all going to be there. So you go one place, you can find everything you need instead of looking all over in all of the announcements. Try to help you there, because I know you have 3 classes, most of you, and it's a lot to keep up with. So I try to help you. Okay. You can go to your modules, go to exam 3. Now, when you are done, you may go home. Does anybody have any questions? Remember, I'm always available if you need to review with me, if you need help with dosage calc, you want to review exam 2, I'm always here to help, okay? I try to make my time as much as I can available for you. I think I did 50 reviews this week. I did quite a few. So whatever you need, just let me know. I'll help. So go ahead, do your quizzes, and I will see you next week for your exams. Yes.